like that some major blood vessels are formed. And so you should know how this tube is converted into a normal shape of the heart. Then development of the valves and conducting system. And then we will see some features about the clinical anatomy. So coming to the development of ventricles, we are seeing that there are 4 chambers formed initially from one tube. One tube is formed from union of the 2 tubes, 2 endocardial tubes, which are placed on the ventral aspect of the embryo. So these are the 4 tubes, of which this one is bulbus cordis. Bulbus cordis. Second chamber is primitive ventricle. This one is primitive atria, and this one is sinus venosus. Okay, these are the 4 chambers. Out of this bulbus cordis is divided into 3 parts. It elongates and develops into 3 compartments, and these are proximal 1/3, which is along with this primitive ventricle. So it is divided into 3 parts. This is the proximal 1/3. Along with this primitive ventricle, it forms a common ventricular chamber, which is then divided into right ventricle and left ventricle. So this proximal 1/3 part mainly forms the right ventricle. How it takes the right position, that we will see in the external appearance of the heart, how it is obtained. So this middle 1/3 is the conus part, which forms the outflow tract of both right and left ventricle. Then this is a transverse arteriosus, which forms 2 important vessels, that is pulmonary trunk and ascending aorta. So this is these are the 3 chambers formed from the bulbus cordis. Okay. Then we are going to see how this tube, which is now having here primitive ventricle, then you get primitive atria, and then you get sinus venosus. So if you label these as a 1, 2, 3, 4, 5, and 6 chambers, okay? Now, how the external appearance is achieved, so that it will be easy to explain about the ventricular septum. So we will finish this part first. Transverse arteriosus and conus are in their same position, but this proximal 1/3 moves to the right and downwards. It moves to the right as well as downwards. As this chamber is going to form mainly right ventricle, it should move to the right, and primitive ventricular chamber will move to the left because it is going to form a left ventricle. Now, primitive atrium, which is again forming right and left atrial chamber, which we have seen already how septum is formed. These chambers will go posterior to these ventricular chambers, and sinus venosus will go posterior to the atrium. So they move posteriorly. So all these movements together will lead to the tube in this way. So this one is the transverse arteriosus, this one is the conus, then you get a proximal 1/3, and then this will be the primitive ventricle. So this will be the proximal 1/3. So if you number them, this is 1, this one is 2, this is 3, and this one is 4. Okay, so these are the 2 ventricles coming to their definitive position or final position. But atria will go behind that, and it will protrude out from the 2 sides of the transverse arteriosus. It dilates, it protrudes anteriorly by the side of this transverse arteriosus. So this will be the right atrium now, and this will be the left atrial chamber. So this is the final position. Now behind the atrium will be the sinus venosus, which will be absorbed in the atria. So this is the external appearance achieved from these chambers. Now we will see how interventricular septum is formed. Interventricular septum has three important parts. These are muscular, bulbar, and membranous part. Now, if you see the heart from the right side, if it is cut sagittally, and you see from the right side, this will be the atrial chambers. Okay? Then here will be the truncus arteriosus and conus in this way, and these are the ventricular chambers. These are ventricle. Okay? Atrium posteriorly and ventricles are anteriorly. See, up to 12th standard you must have learned that atria are above the ventricles, but actually in final position they are not exactly above, but they are posterior to the superior part of the ventricles. They are posterior to the superior part of the ventricle. This you should remember. Okay, not only this, but they are slightly to the right side actually. Okay, now atria are separated from the ventricles by the atrioventricular cushions. They grow towards each other and form a septum intermedium. They form a septum intermedium. So this one is the truncus arteriosus, here is the conus, and this is the ventricle which is formed by the primitive ventricle chamber and proximal 1/3 of the bulbous cortex. Now again, if you take a section here, suppose this is a X and Y, how it will look? See, truncus arteriosus, conus, then you get these ventricles. Okay, it is like this. Okay, this part is less, this part is more. So this one is the truncus, which is now going to form a spiral septum, which we will see afterwards. These are the walls formed the aorta as well as pulmonary trunk. Then this is a conus part, and on the dorsal wall of these ventricles there are two openings, atrioventricular orifice. These two are atrioventricular orifice, and this is the septum intermedium formed by the ventral and dorsal atrioventricular cushions. Okay, now from this conus part, two regions are formed which move towards each other, and this is the formation of the bulbar septum. There is right and left bulbar septum, which forms and descends downwards. This is the right bulbar septum, left bulbar septum. It is formed by a ridge. The ridge goes downwards and unites with the ridge of the opposite side. Now this right ridge is slightly dorsally placed and left ridge is slightly ventrally placed. So left ventral and right dorsal may be named like this: left ventral bulbar ridge and right dorsal bulbar ridge. These two ridges unite and they descend down. So this is one part. This is the bulbar part. Bulbar part of the interventricular septum. Okay. Now from the floor, the muscular sheath develops. It is in this direction. Okay. Muscular sheath develops. This sheath, as it is muscular, it is coming from the muscle cells, myocardium. Okay, these are the mesenchymal cells. Glycophilic disorder is there, which gives rise to myoepicardial mantle, which forms the myocardium. And from these myocardial cells, the septum is going to form. So it is known as muscular septum. It is known as muscular septum. Now this septum is not exactly vertical, but it is twisted because it is having two horns. One horn is known as dorsal horn and another horn is known as ventral horn. Dorsal and ventral horns, out of these, this dorsal horn goes to the dorsal cushion, dorsal AV cushion. We have seen here, this is dorsal AV cushion and ventral AV cushion. So it goes to the right side of the dorsal AV cushion and left horn, this is the left horn, goes to the left side of the ventral AV cushion and its upper margin is twisted. Because of this, upper margin is twisted, it is curved, it is concave above, and the septum whole is twisted. As the upper margin is twisted, the whole muscular membrane is twisted one. It is having a length of near about 8.3 to 11 millimeters. Okay. So this is the mean of various heights of this septum. Okay. Now this upper margin is free. Upper margin is free. Now bulbar septum is coming down. Still there remains a gap. Okay. There remains a gap here, which will be filled by proliferation of the AV cushion. Proliferation of the cells in the AV cushion, and this will be filled. Okay. Now proliferation of the AV cushion is mainly from the right side of the AV cushion. Okay, right side of the cushion. So these are the three parts. This is bulbar part. From AV cushions, whatever gap is filled, that is membranous part, and remaining is muscular part. Any defect or any gap in this process will lead to the orifice or lead to the communication between right and left ventricle. Why this septum is developing? It has to separate right and left ventricles. But if they fail to form a continuous sheet, there will be an opening, and that opening will lead to the communication between right and left ventricle. That means deoxygenated blood will be mixed with the oxygenated blood, which will lead to cyanosis. So next figure where this septum is formed is like this. Okay. Now bulbar septum is coming like this from above. Then there is a cushion, AV cushion, which gives us the proliferation of the cells, and here is this septum is the muscular part. So these are the three parts. There is a small orifice here. Depending on its size, there will be a mixing of the blood. If orifice or communication between right and left ventricle is large one, then deoxygenated blood and oxygenated blood will mix to a larger extent, and so there will be cyanosis and it is incompatible with the right. But if the orifice is very much small, then mixing is less, and so that condition is compatible with the life. So this is about the bulbar septum, muscular septum, and one more septum is membranous part of the interventricular septum. So you should know three parts of the interventricular septum by which the ventricle chamber is divided into right and left ventricle. So we have finished how ventricles are formed, interventricular septum, in external appearance of the heart. Now coming to the development of the valves. Now there is a formation of the pulmonary valve, and first we will see atrioventricular valve. Okay. Then we will see pulmonary valve. So atrioventricular valves are present in between atria and ventricle. Right and left orifice is there. And first they will form cushions. There is a dorsal cushion, ventral cushion. Okay. And how these cushions are formed, that is important. Suppose this is the endothelium. it is like this, okay? Then deep to this, you will get some connective tissue, okay? And after that, you will get myocardium, okay? So this is suppose myocardium, myocardial cells. These are the muscle cells, okay? So you should know that this is endocardium. Now deep to endocardium, whatever subendocardial tissue is there, that will proliferate and there will be a formation of such structure which will form a wall or cusp. You can call it as a cusp. So these cells will migrate here and form a ridge-like structure which will form a cusp. Okay? These are not muscle cells. These are subendothelial cells. Okay? Subendothelial tissue. Okay? Whatever cells are there, they proliferate and form a ridge-like structure, and in this way the cusp is formed. So this is about the atrioventricular wall. In this way, you will get tricuspid wall and mitral wall. Coming to the pulmonary wall and aortic wall. Pulmonary wall and aortic wall, they also have at the beginning only one orifice. There is only one orifice, and on the right and left side there is a formation of the cushion. Okay? These cushions also develop ventrally, dorsally, and on two sides. First, they are on two sides here. Then they develop ventrally and dorsally. Okay? Now, whatever this rounded structure is there, there is a constriction like this. Okay? And this cusp, right and left cusp are divided into two, but ventral and dorsal remain as they are. Okay? Ventral and dorsal cusp, they remain as they are. We are going to see aortic and pulmonary orifice. Okay, aortic and pulmonary orifice. So it is divided into two parts. As this constriction deepens, the two separate orifices with cusps are formed. Okay, this is one and this one is another. Now here you get these three cusps like this. Okay, this posterior one is aorta. And anteriorly, what you get? Anteriorly, you get a pulmonary trunk in this way. Okay? This one is a pulmonary orifice. Okay, pulmonary orifice, not trunk, it is a pulmonary orifice and aortic orifice. Now this pulmonary orifice and aortic orifice, out of this pulmonary orifice is ventral and aortic is dorsal. Now they rotate in an anti-clockwise direction. Anti-clockwise direction. So what happens? They get placed obliquely like this. Okay? So that this one is aorta, this is a pulmonary trunk. Here you get one anterior. Because of the movement like this will come anteriorly. Okay? And this will be the left posterior cusp, and this will be the right posterior cusp. Right posterior. Okay? Left posterior, right posterior, and this one is anterior. So you know here that there are aortic sinuses, and from anterior aortic sinus, right coronary artery emerges, and from the left posterior sinus you get the left coronary artery. In the case of pulmonary, now you will get two anteriorly placed and one posteriorly placed cusp. Okay, this is anterior right, this one is anterior left, and this one is posterior. So this is the final composition of pulmonary orifice and aortic orifice and their cusps. Okay. Now coming to the truncus arteriosus, how it divides into two and gives rise to the pulmonary trunk and ascending aorta. So pulmonary trunk, first it is anteriorly placed. So if you see, suppose this is a truncus arteriosus. Now in this will develop a spiral septum. This spiral septum is coming from the neural crescents. Not only spiral septum, bulbar septum, semilunar walls are derived from the neural crescents. So now we will show a spiral septum will develop in this fashion, so that it will be having a spiral course like this. Okay, it is having a spiral course like this. This is a spiral septum in truncus arteriosus. Truncus arteriosus. Okay, so this one is a spiral septum. This is a spiral septum. So it divides the truncus arteriosus into two compartments. Now these two compartments are nothing but the pulmonary trunk and aorta. Now if you take a cross section here, in the middle, here and here. So you should know these three cross sections at the proximal end, middle and at the distal end. If you see the proximal end, the septum is coronary oriented. In the middle, it is antero-posteriorly oriented. This one is a septum, spiral septum. Okay. And here again, it is coronary oriented. So it is going to twist. First, it is like this. Then it will move like this, and then again it will go coronary. Okay. So here the anterior or ventral portion forms the pulmonary trunk. Pulmonary trunk. Okay. This portion will form a aorta. This is the ascending part of the aorta. This is ascending part of the aorta. Again here, this ventral portion will go here. So this will be the pulmonary trunk, and this is the aorta. Again here, aorta is coming anteriorly or ventrally, and pulmonary trunk is going posteriorly. So there is a twisting of this. Now if you compare this, the final position is pulmonary trunk is posteriorly. So in our body, if you have seen the heart carefully, the arch of aorta and ascending aorta are like this. Okay. Now the pulmonary trunk, which is coming here, it is anteriorly placed first. Okay. Then it comes to the left. See, pulmonary trunk is anteriorly placed. Then it goes to the left. So this is the position of the pulmonary trunk. Then it goes back. Okay. Posterior to this, where it divides into two. Okay, in the posterior plane, it is dividing into two, like this. Okay. So, to occupy this position, there are changes in the spiral septum like this. Spiral septum is first coronary arranged at the proximal level. In the middle part, it is anteroposterior, and in the caudal or cephalic region, it is again coronally placed. Pulmonary trunk, which is anteriorly placed, goes to the posterior aspect. Now, if you see this spiral septum, at the distal end it is coronally placed, and above the truncus arteriosus there is a aortic sac. There is a aortic sac, and in this aortic sac there is a aortic sac. This spiral septum which is coming here, it will go up and get attached to the dorsal wall of the aortic sac. Dorsal wall of the aortic sac. How aortic sac is there? What are the two horns? How it gives rise to aortic arches? That we will see in the next lecture. Coming to the clinical anatomy. Clinical aspect. The first important thing is the dextrocardia. Dextrocardia. Here, left-sided structures of the heart will develop on the right side, and right-sided structures will develop to the left side. So, what are the changes? Superior and inferior vena instead of on the right side, they will come to the left side, and pulmonary veins which open into the left ventricle will come to the right side. In this way, there is a change in their site. Right structures will go to the left, left structures will develop on the right side. This may be a part of the situs invertus. Situs invertus. What is this situs invertus? This is a condition in which all organs of the body which are situated on the right side will develop in the left side, and left-sided organs will be on the right side. For example, liver should be on the right side, it will develop on the left side, and spleen, which is on the left side normally, it develops on the right side. In this way, the situs invertus baby shows the structures which are on the right side develop on the left side, and left-sided structures will develop on the right. So, dextrocardia may be a part of situs invertus, or it may be a separate entity. It may be a separate entity. Second, you should know is ectopia cordis. Ectopia cordis. In this condition, the heart is exposed outside on the anterior aspect because there is a defective development of sternum, anterior thoracic wall, and so heart is exposed to the environment. Third structure is atresia or stenosis of great vessels, pulmonary vessels or aorta. Okay, if pulmonary artery or pulmonary trunk is having a stenosis, what will happen? Pulmonary trunk is coming from the right ventricle, so the right ventricle should contract more. That's why, as the function of the right ventricle increases, it undergoes hypertrophy. As there is a right ventricular hypertrophy, right atrium will also undergo hypertrophy, and foramen oval will not close because of the more pressure on the right side of the heart. And right side develops more than the left side. Left side will be rudimentary when there is a pulmonary stenosis. When there is a aortic stenosis, because of the pulmonary stenosis, there is a patent foramen oval. Not only this, there is a patent ductus arteriosus also. What is this ductus arteriosus? We are going to see in the next lecture. So, when there is a stenosis of pulmonary trunk, there is a hypertrophy of the right ventricle, right atrium, persistent open foramen oval, along with that patent ductus arteriosus. When there is a stenosis of aorta, aortic trunk, then you get patent ductus arteriosus. Next, you should know about the abnormal growth. It may be malignancy, may be a benign tumor. Abnormal growth in the form of more cusps will be there, or more septum, part of the septum will be more, or new septum will be formed instead of one septum. So these are the various structures you will get. Now along with this, now there is one more condition known as trilocular heart. Now trilocular means 3 chambers will be there. This is divided into 2 types. It may be biventricular or it may be biatrial. Biventricular or it may be biatrial. Trilocular means 3 lobes are 3 chambers are there. Biventricular means 2 ventricles and 1 atria. So 3 chambers are there, or 2 atria and 1 ventricle. In this way, it may be trilocular with 2 atria. It is known as biatrial. Okay. So when you mention the disease, it is known as trilocular biventricular heart or trilocular biatrial heart. Okay. Now coming to the some septal defects. In septal defects, you get atrial septal defects and ventricular septal defects. Along with that, you may get spiral septal defects. Spiral septum is formed in the Transverse Artery. So, atrial septal defect. In atrial septal defect, you may get in the persistent ostium primum. Ostium primum is formed as the septum primum descends down. It doesn't reach up to the septum intermedium, and so whatever foramen is there, that is known as ostium primum. As the ostium primum crosses, ostium secundum is formed at the cranial end. If septum secundum is not formed, then ostium secundum will be a large orifice through which deoxygenated and oxygenated blood will mix with each other. So, whenever there is a persistent ostium primum, that is also not normal. Persistent ostium secundum, when there is no formation of the septum secundum, this is also one condition. Coming to the ventricular septal defect. Ventricle is having membranous part and muscular part mainly, which will have an orifice inside them. Now, this orifice, if it is in the muscular wall, as we have already discussed, if the opening is very small, communication is very small, then there is a least mixing of the blood. So, it is compatible with the life. But if it is a large opening in the membrane, in the muscular part, then there will be mixing. Large amount of deoxygenated blood will mix with oxygenated blood, which will lead to the cyanosis. And a stage will come when the patient will not survive. But if there is a defect in the membranous part, it is very dangerous because membranous part is very close to the atrioventricular orifices. It is very close to atrioventricular orifices. Whenever there is a defect in the membranous part, it is possible that 4 chambers communicate with each other and all blood is mixing with each other, and this deoxygenated and oxygenated blood, mixed blood, will be supplied to the each and every cell. So this is a ventricular septal defect. When there is a spiral septal defect, spiral septum completely separates ascending aorta and pulmonary trunk. When there is a defect in these structures, aorta and pulmonary trunk will be in communication with each other, and this is also very dangerous. So these are the various types of the septal defects. Now coming to the atrioventricular orifice defect. We have seen that if membranous part of interventricular septum is defective, then 4 chambers will communicate with each other. In the same manner, if there is a defect in atrioventricular orifice, this also leads to the communication between the 4 chambers. Okay, communication between the 4 chambers. So this is also not compatible. Next abnormality you should know is a combination of these various defects. Combination of various defects. And under this, you should know about the Fallot's tetralogy. Fallot's tetralogy. What is in this Fallot's tetralogy? We will say this is the right ventricle, this one is the left ventricle, here is the septum. Okay? Now, pulmonary artery should originate from the right ventricle. Now, there is a stenosis of this trunk, pulmonary trunk. So, this is the first picture, stenosis of pulmonary trunk. Okay? Pulmonary trunk. Stenosis of the pulmonary trunk. So, there will be hypertrophy of the right ventricle. Hypertrophy of the right ventricle, as right ventricle has to contract more to pull the blood to the pulmonary circulation. So, there will be hypertrophy of the right ventricle. As there is a stenosis of the pulmonary artery, the aorta will come and it will override right as well as left ventricle. So this is the aorta. So aorta will carry blood from the left as well as right side. So it is again a mixed blood. On the left side you will get pure blood, oxygenated blood, and on the right side it is a deoxygenated blood which will be carried by the aorta. So along with this, there is a, as the aorta is coming here, means there is a ventricular septal defect. Ventricular septal defect. So, four parts of the Fallot's tetralogy are stenosis of pulmonary trunk, then hypertrophy of the right ventricle, hypertrophy of right ventricle, okay, then overriding of the aorta. As there is a space, it will come to the right, overriding of aorta and ventricular septal defect. So these are the four components of the Fallot's tetralogy. Now coming to the next defect, that is developmental defects, and these are pericardium, which should surround the heart, is not formed at all. Agenesis of pericardium. Very rare, but it is there. Then you may get agenesis of conducting system. Agenesis of the conducting system. So conducting system, which includes AV node, SA node, bundle of this, right bundle branch, left bundle branch, and through this, the message is carried through Purkinje fibers. Out of this, the SA node is placed in the left. When there are two endocardial tubes developing, this SA node is present in the caudal part of the left endocardial tube. These two tubes unite and SA node is shifted to the sinus venosus. When there is an incorporation of the sinus venosus into atria, it goes to get a position near the opening of the superior vena cava. So this is a SA node. Okay. AV node is present in the sinus venosus left wall of the sinus venosus. As sinus venosus is absorbed, it goes near the interatrial septum. Okay, so this is a normal development if they are not formed. So this is also one defect, developmental defect. Now some other conditions are transposition. Transposition of great vessels, that is pulmonary trunk and aorta. Transposition means what happens here? Suppose this is one ventricle, right ventricle, this one is left ventricle. Pulmonary trunk will come from the, usually it should come from the right ventricle and aorta from the left ventricle. Okay. Aorta from the left ventricle and pulmonary trunk from the right ventricle. Okay. So this is the common position. But instead of this, there is a transposition. So aorta will come from the right ventricle. So aorta will be coming from the right ventricle and pulmonary trunk will be coming from the left ventricle. So this is the pulmonary trunk. Here is the pulmonary trunk. This one is aorta. This is normal. This one is abnormal. Okay. This is the aorta. Now, what will happen in this condition? Okay. We will see that pulmonary trunk is in communication with the left ventricle, which is having oxygenated blood. Now, pulmonary trunk will carry this oxygenated blood to the lungs, and again from lungs, it will be delivered to the left atria through pulmonary veins. So, oxygenated blood will not reach any cell. It will be in the pulmonary circulation only, as it is not connected to the systemic circulation. What happens here? Aorta will carry a blood from the right ventricle, which is a deoxygenated blood. Through aorta, it is carried to each and every cell. So this deoxygenated blood, which is having less oxygen, it will be supplied to the cell. And these two circulations will be totally different. They will not communicate with each other. So deoxygenated blood will be carried by aorta and oxygenated blood will be carried by the pulmonary trunk again and again to the lung for oxygenation. So this is the defect. So this is about the transposition of the great vessels. Next, you should know about one syndrome that is known as toxic wing syndrome. Toxic wing syndrome. What happens in this? Suppose this is again heart, right and left ventricles are there. Aorta is coming from the right ventricle. Aorta is here coming from the right ventricle. And there is an overriding of the pulmonary trunk. Pulmonary trunk will take origin from right as well as left ventricle. This is known as toxic wing syndrome. See the spelling, you should write correctly. Okay. Some more anomalies are there. For example, superior and inferior vena cava, instead of opening into the right atrium, they open into the left atrium. So, if the heart is like this, so these two are atria, and here is a ventricle. Okay. So here is the septum, there is also septum, there is a septum, it modifies. Okay. Now, superior and inferior vena cava will come and open into the right atrium. Inferior vena cava and superior vena cava. Okay. And pulmonary veins will open into the right atrium. Pulmonary veins open into the right atrium. These are pulmonary veins. So there is a change in the site. Okay. So this is one anomaly which you will get. So these are some important anomalies which I have covered. Go through this. So here we are going to stop. We have finished development of ventricles. Ventricles, right ventricle is mainly formed by the proximal 1/3 of the bulbous cordis, and left ventricle is formed by mainly primitive chamber. This forms one chamber which is again divided into interventricular septum, which is having three parts: muscular part, membranous part, and bulbar part. Bulbar part develops from the conus. which will form outflow part, which is a rough part. Okay, and primitive ventricle is there. External appearance of heart, they have seen how various chambers are there and they take their respective positions by forming U tube, S tube and various parts. Then development of valves, they have seen how atrioventricular valves develop, how valve in the aorta as well as pulmonary trunk develop. And we have seen clinical anatomy. One more important part is that these two are atria, okay, and here is the ventricle, okay, and here you get an interatrial septum. Now here you get septum intermediate. Now interatrial septum will come and join this. Interventricular septum will come and it will join here. Okay. So these are not coming in the same vertical plane. So whatever this membranous part of the septum is there, interventricular septum is there, this membranous part is divided into two parts, anterior and posterior. Anterior and posterior. Anterior part is in between two ventricles, in between right and left ventricle. But posterior part is in between right atrium and left ventricle. This is very important. This is very important. See, membranous part is having two parts, anterior part and posterior part. Anterior part is between right and left ventricle, and posterior part is between right atrium and left ventricle. So this part, posterior one, forms the atrioventricular septum. This is known as atrioventricular septum. So if you mention about this part also, you get more marks. So here we are going to stop. Right.